All right, so hopping back into this, we're in section 4F now, which is asystole. It's talking about your cardiac arrest rhythms. Asystole is very, very simple. You look over on your treatment priorities, nothing changes. Your CPR, apply rescue CPR within 2 minutes, 80 minutes for rescue CPR, 110 for standard CPR. Evaluate and treat underlying causes, your vasopressor administration, and then following protocols 4A, 4B. So for vasopressor administration for adults, looking here at the bottom, epinephrine 1 milligram IV push, IO push, repeat every 3 to 5 minutes. And then your pediatric is 0.1 milligrams per milliliter, 1 to 10,000 at 0.01 mg per kg. 0.1 milliliters per kilogram IV push, IO push, repeat every 3 to 5 minutes. So with pediatrics, the easiest way to do any medication administration, any defibrillation, anything like that is to use your HandTevi app. We have the HandTevi app. We pay for it, so use it. It's very, very easy to use. It will save you a lot of time. It will make sure that you don't do any incorrect math, anything like that. And if you don't know how to use it, then ask one of us and we'll walk you through it. We'll make sure that you have login on your phone. You should have a login on the phone on the ambulance or the engine or ladder. It's very easy to use, and it saves you a lot of time, and it'll save you from some simple mistakes. So anytime you're using pediatric or on a pediatric call, make sure you're using HandTevi. So we're going to go out of here and we're going to go straight into 4G, which is your VFib pulseless V-TAC adult and pediatric. The only treatment priorities in the yellow box that are added on this is number 2, which is timely defibrillation, and then number 5, which is timely anti-arrhythmic administration. So we go down here to the paramedic box for manual defibrillation. I've said this several times. We'll continue to say it. We're saying it for a reason. May or may not be good for you to know for testing purposes and real life. So pause CPR for a single shock. Limit defibrillation compression pause to a maximum of 10 seconds. So when you go back to what we were talking about earlier with the double sequential shock and what we talked about with the weight and everything, it's right here. So if the patient is less than 100 kilograms, you will start your defibrillation at 200 joules with one monitor, even if you have 2 monitors on scene. You can go ahead and hook up the other monitor and all the pads and stuff, but you don't want to waste any time to do that. And so if they're under 100 kilograms, your first defibrillation will be 200, the second one will go to 300, and the third one will go to 360. This is all assuming that they stay in a shockable rhythm and they don't obtain ROSC or go into asystole or PEA. On the fourth shock and everything after that, you will go to double sequential external defibrillation. And that's what we talked about in protocol 4E. Now, if the patient is over 100 kilograms, your first defibrillation is going to be 360 joules. And then after that first shock, everything will be at your double sequential external defibrillation. For pediatrics, again, HandTevi. It will walk you through exactly how to do it and how much you're doing. But for initial defibrillation, it's 2 joules per kg. And your second and everything after that is going to be 4 joules per kg. Count AD defibrillations prior to determining manual defibrillation setting. Your vasopressor administration, epinephrine, adult, again, and pediatric, it's the same dose. The only change with this is if they are in a shockable rhythm, so ventricle fibrillation or pulseless ventricle tachycardia, your maximum cumulative dose is going to be 3 milligrams. So simplifying that, you will give epinephrine 1 milligram for adults or 0.1 milligram per milliliter for pediatrics every 3 to 5 minutes. You will only give 3 milligrams over that time. So you'll give 1 milligram every 3 to 5 minutes. And then once you hit that 3 milligram mark, so you've given 3 doses of epinephrine, you will not give any more unless they go back into if they go into or back into asystole or PEA. So this has been a common confusing point for some, so I'll try to explain this a little bit better. If you start an asystole or PEA, you don't have a maximum cumulative dose. Okay, so you will give epinephrine every 3 to 5 minutes. If you start in asystole or PEA and say you go into ventricular fibrillation or pulseless VTAC at that fourth dose, you just will not give another dose of epinephrine. Okay, if you start in VFib or VTAC and you've given those 3 doses and they go into PEA or asystole, at that point you can go ahead and administer more epinephrine. So just remember, the most basic way to remember it is if they're in a shockable rhythm, your maximum cumulative dose of epinephrine is going to be 3 milligrams. If they're not in a shockable rhythm, there's no maximum cumulative dose. If I'm confusing you by saying that or you don't understand, again, please ask and we will try to better explain it. So below that, you have your antiarrhythmic administration. For adults, again, for ventricular fibrillation or pulseless VTAC, you have amiodarone. So your first dose of amiodarone in cardiac arrest for a shockable rhythm is going to be 300 milligrams IV IO push. Your second dose will be at 150 milligrams IV IO push in 5 minutes. Your maximum cumulative dose for amiodarone in an adult patient is going to be 450 milligrams. I would know that. I would know both of those and the order and then your maximum cumulative dose. For any time you give amiodarone, you will follow it with 1 milligram IV IO push epinephrine. So when you give, just make sure when you get to that rhythm analysis and it's time for medication administration, they're in that shockable rhythm, you defibrillated, and it's time to give that medicine. You're going to give amio first, and then you're going to follow it with epi, and then open your line to your normal saline or flush or however you're doing it. So just make sure when you give amio, you're going to follow it with your epinephrine. For torsades, our medication is going to be magnesium sulfate, and that is 1 gram IV IO push. And if you don't know what torsades is, we can show you what torsades looks like. It's a polymorphic pulseless ventricular tachycardia. So for ventricular fibrillation or pulseless VTAC, we're going to go amio followed by epi. For torsades, we're going to go mag sulfate. For pediatrics, again, Hand Heavy will tell you all of this, but amiodarone is going to be 5 milligrams per kilogram, IV IO push, single dose. Hint, single dose. Remember that. And then epinephrine is the same with your amio administration. If successful conversion sustained pulsatile rhythm, return of spontaneous circulation. So what that's saying is if you are in a cardiac or work in a cardiac arrest and they are in, say, ventricular fibrillation or pulseless VTAC, and you obtain ROSC, you will do all of your ROSC stuff that we will talk about later on. And then if you've only given 300 milligrams of amio, so you've only given that first dose, you can go ahead and give a second dose of amiodarone, and it's going to be 150 milligrams IV push bolus. And how you're going to do that is you're going to put that 150 milligrams into a 100 milliliter normal saline bag, and you will infuse it into the patient, IV or IO, over 10 minutes. For pediatrics, you have to call online medical control to do this. So, and they will tell you yes or no. So again, your maximum dose is 450. So if you've already given 450, you're not going to hang a drip during ROSC. If you've only given 300, you can hang a drip of amiodarone 150 milligrams. So the next one's really short, so we're going to go ahead and just add that one to this. And it is PEA, pulseless electrical activity. The protocol for PEA is the exact same as asystole. There is no difference. The treatment priorities are the same, and your vasopressor administration is the same. And that is the only thing on this whole protocol. So that will be it for those three. Again, any questions, feel free to ask.